Good morning, everyone. So this session is being recorded for those who are not able to join. So we'll start on time. We'll keep admitting people as they come in. And I appreciate those who dedicated the time to spend an hour with us in learning about Group A Strep. I don't claim to be an expert in it, but we are forced to review all the guidelines just because we started having cases in a long-term care setting. And so it's reasonable to review all the knowledge and all the information that's available in both, the scientific literature as well as government guidance, CDC, and Massachusetts DPH. So we'll start the presentation, and I'm going to be happy to answer any questions at the end. We'll go through the slides with overview of Group A's strep infection and the forms, different forms of it, and most importantly, what to do, what nursing team is to do about it, and how we can help minimizing the chance of our patients getting wound infections and treating them right away and addressing the cases. So Group A strep infections 3 to 8 times more common in a long-term care setting versus the rest of the community. The hospital setting is also prone to it, but we're going to be focusing on how to prevent the infections in a long-term care setting. Case fatality is pretty high due to invasive strep and necrotizing fasciitis cases, and especially in adults 65 and up. It could be very fast developing, so that's why we want to learn the trigger points at which we have to escalate the case. We need to recognize it earlier, tell it apart from other infections such as MRSA. And we're going to be talking about wound cultures, but the best wound culture is done right after debridement, where you're culturing deeper tissues. If you're suspecting any cases, and this has just been developed, we're happy to culture this during wound rounds, but if we'll be talking the cases where you cannot wait, and you will need to transfer the patient to ER. Isolate correctly and timely, prevent the spread, and escalate and report. Streptococcus pyogenes, that's the full name of Group A strep as that we are talking about. That specific species, it's strepto means chains, so when we look at the bacteria under microscope, it appears to be the cocci, the round species in the chains. And pyogenes means pus generating. So it's a bacterial infection that generates purulent exudate. Common cases coming from strep throat. And strep throat, as you may know, we treat strep throat with antibiotics to prevent any damage to the heart and possible damage to the joints. So you may have experienced during your lifetime a strep throat infection where we treat the patient with antibiotic. Strep throat happens to transfer into the wound as the provider who is having symptoms of strep throat is not wearing mask and not following droplet precautions. Contact precautions are also need to be followed. So two ways of spreading, basically, droplet versus contact. Our patients are at risk because they're frail, they have immune compromise, and diabetes and poor perfusion is also contributing to the wound infections. Chronic wounds and pressure injuries are common sites of Group A strep infections. Shared rooms, shared caregivers, and fragile skin and indwelling devices. So we'll group them in 3 different groups. So it's a localized infection, impetigo, cellulitis, infected wound versus invasive, causing bacteremia, pneumonia, septic arthritis, Those definitely require systemic antibiotics, oral versus IV, depending on the severity of the case. Then life-threatening necrotizing fasciitis. This is a medical emergency. It needs to be this patient needs to be transferred to emergency room to see a general surgeon right away to perform fasciotomy, to perform operating room scale of debridement. So this is the third category of cases, and not to be consulted to us because we're not going to be responding in a timely manner. We are non-urgent service, and we are available after you're outside of your wound rounds window, but we're mostly going to be available remotely via telemedicine. So life-threatening infections, that's immediate ER transfer. We can talk through this case later on, but we want to make sure we're saving life. So we're saving patients' life by transferring them to appropriate surgical care, and debridement. Surgical debridement in the operating room setting is the key treatment, followed by antibiotics. Signs and symptoms include spreading redness, warmth, and swelling, new or worsening pain, purulent and foul-smelling discharge, drainage from the wound, a rapid change since the last dressing change, darker skin, purple hue, and warmth to touch, perianal redness that is new and it's increasing and increasing in severity, and it's painful because usually diaper dermatitis, the incontinence dermatitis is not as painful and not as fast spreading. Watch the resident. So our immunocompromised patients, our dementia patients may not be actively complaining about the change. You may see new confusion or mental status change, new fevers, unexplained fever and chills. We wanted to investigate and see where it's coming from. Low blood pressure is definitely a significant sign. The patient might be becoming septic, and fast heart rate is also a response to that insult of the body that strep A infection is causing. How to distinguish Group A strep from others that mimic the GAS infection? Stasis dermatitis is something that is mild redness, usually of chronic nature. It's not changing in size. It's accompanying leg ulcers, particularly lymphedema and venous disease ulcers. And it's not painful to touch. It's staying there. The other clue is it's most likely going to be bilateral, so both legs are affected at the same time in equal severity, equal redness. So always compare to the contralateral side. So if you have a patient with wound on the right side, always look at the left, and especially if patient is wearing pants or not the left side is not accessible for physical exam right away. So just look at the whole picture and see if this is a true cellulitis and this is faster spreading cellulitis. That's where GAS may be suspected. MSD. Like we said already, so MSD is moisture-related damage that is usually not fast spreading, not painful, and it's due to moisture, and it's appearing on the skin folds, on the peri-wound, periostomy. Skin damage might be occurring due to moisture, but this is more of a chronic development rather than acute development. And chronic colonization, stable wound, bacteria present and without spreading infection. So we don't necessarily advise to treat this patient with antibiotic, and chronic colonization of the wound is something that we do reduce by performing appropriate wound debridements every single week if needed. Again, the key word is if needed. And we use also, we're going to be talking about antibacterial cleansers. And like I said, I'm looking forward to discussion because we need to team up and share the knowledge and make sure that we're working as a team because everyone is as important on a team. There's no top-down approach here. The key when you obtain the culture is not to treat the culture because you might be dealing with a chronic wound colonization. So culture needs to be only done when it's appropriate. You don't want to be swabbing in the entire resident population, the entire building. So this is the wrong approach, and that is something that's going to be revealing false positives and may lead to overtreatment. I think recognizing the symptoms and telling apart the chronicity versus acuteness. So acute illness is where GAS will be suspected. Necrotizing fasciitis and toxic shock syndrome will be presenting with pain out of proportion, rapidly advanced margins, and expanding redness, and this is happening minutes to hours, not days. Dusky purple and blistering skin, large bulla over the area, large blisters over the area. Crepitus, that's another, so it feels like you're stepping on the snow as you're palpating the wound or the skin surrounding it. Skin numbness is very, very critical sign of the necrotizing fasciitis because this swelling that might be causing the nerve damage. So again, this will need to result in an immediate transfer to ER. Systemic toxicity, low blood pressure might be a sign of sepsis, confusion, and just looking like this is the person is about to die. So definitely very, very debilitating, very life-threatening condition. Antibiotics do not replace surgery, just to, again, reiterate the important points here. The third, again, remember we grouped into three groups. The third, the most severe group, the necrotizing fasciitis, will not, these patients will need antibiotics, but not immediately. The surgery is the most immediate thing to do. So course of action, recognize and assess, isolate as soon as possible, notify the provider. So primary care physician needs to be called first, us second call. We would love to provide any guidance. We do have this protocol to share. We're going to be emailing you the PowerPoint slides as well as a Word document of the protocol that you can adapt. There's a specific reason why we're sending this in Word editable format, so you can discuss among yourselves, among your facility chain, and make necessary adjustments. So it has to be a group effort. It has to be a good group document that is the most precise to your facility needs. Culture. If you're thinking of giving the first antibiotic dose, culture first. That would be the best culture. So your antibiotic does not skew the culture towards something else. So it will be not very accurate result. Culture, again, ideally should be done as a deep culture, and we happy to talk through at the bedside when we do wound rounds. We can talk with your wound champion how to perform cultures when we're not available. And like I said, we're happy to perform cultures after debridement if this is our common suspicion. So a multidisciplinary team is suspecting Group A strep, and we want a culture. we definitely can do that. Document and flag, and we'll talk about reporting guidelines as well. Precautions, contact and droplet precautions for all wound care related issues. Throat, only droplet precautions. And arguably, we're all used to wearing masks, whether we like it or not. We've gone through COVID. So I think this is the easiest intervention you can do in your building, just to reiterate masking and the general contact precautions when treating the wounds, especially for wound rounds, making sure that we don't transfer infection from one person to another. And by the way, we are reporting pretty much weekly zero infection rates in our buildings in the patient population that's on our consult list. How to prevent Group A strep? So ideally, if at all possible, use single resident topicals only. So single bottle of wash or similar antibacterial cleanser, sterilely packed 4x4s. That's not a larger box that's you open and transfer from room to room, but rather you probably see us carrying the 4x4s that are 2 each in a sterilely packed package. So those I prefer. They're not as critically expensive and unaffordable as you might think. This is reasonable. It's a Medline product, so it's a generic product that is safer for the patients. At least if we having these types of supplies present for each patient on an individual basis and not transferring those supplies from room to room, I think it's going to be a step up towards minimizing or even eliminating Group A strep infection in our buildings. Disinfecting reusable instruments between the residents and sunny cloth wipes are preferred way. DPH prefers us to use sunny cloth wipes, and alcohol swabs are or alcohol-based, 70% isopropyl alcohol sanitizers are acceptable for hand sanitizing, for other, for disinfecting instruments, but sunny cloth is the preferred way of disinfecting reusable instruments like bandage scissors or anything else that you have to carry from resident to the resident. But like I said, we're going to be teaming up with every building. We're going to be teaming up with every single wound champion that we have, who we have, and we'll talk through minimizing anything that we can make it single resident use. We will be talking about doing that rather than even disinfecting with sunny cloth. Is if we can minimize it, if we can keep it single resident use, that would be the best solution. Clean to dirty wounds. So if you see the residents with multiple wounds, we want to start with the cleanest first, the non-infected wounds first, dress them up before going to the more soiled or presumably dirtier area of the body. Kind of clear-cut case, I would, clear-cut example I would make, something on the face, considered to be cleaner versus, sacral wound, it would be more likely to be contaminated, not necessarily with Group A strep, but overall bacterial loads in the buttock / rectal area and groin area is usually much higher than other anatomic locations. Vash is preferred, and we have multiple other brands that might be more affordable. Medline product is also very, very compatible. It's the same chemical structure as Vash, and hypochlorous acid cleanser is preferred way to cleanse the wounds and prevent Group A strep. Again, not as expensive as you might think. This is a reasonable step in terms of replacing your normal saline or replacing your generic antibacterial wound cleanser. So you just the hypochlorous acid will provide a slightly higher acidity, and that's going to kill more bacteria. So and hypochlorous acid is still safe for every single chronic wound because it does not stall the wound healing. So a wound still continues to heal without cytotoxic damage that hydrogen peroxide or other very heavy acidic solutions might create. Again, hydrogen peroxide, betadine, and high-strength Dakin solution, they're not preferred treatment. Hypochloric acid is preferred treatment as a cleanser. So hand hygiene, between clean and dirty areas, even on the same resident, we want to make sure that we have alcohol sanitizer available and a fresh set of gloves. Gloves that are recommended are nitrile gloves because they're less likely to break during wound care procedures. The other types of gloves, vinyl gloves, are preferred for non-wound care, non-procedural care. So, they still acceptable as long as the box says that's for medical use and not for dietary use. So there are some highly porous vinyl gloves that we're not going to be using because the package says it's not for medical use. It's only for culinary use, for the kitchen use. So just make sure that the package says this is nitrile gloves. They're not as expensive as you might think. I think it's, again, reasonable thought towards prevention of Group A strep. Talked about hand hygiene, so it has to be a 70% alcohol in hand sanitizer, and DPH also looks at expiration dates. So make sure that the expiration date is clear and it's readable on each container. Enhance barrier precautions for the residents with wounds and indwelling devices. Clean and disinfect shared equipment, wound cards, vitals card, lifts, residence areas. Skin and wound surveillance, look closely and making sure that you're catching the major acute changes in the wounds. And then culture and early reporting, early escalating the case if this is more of kind of like medical emergency, or the second group that we talked about, the Group A related cellulitis. So that is requiring systemic antibiotics. So the topicals that we usually use for milder cases are no longer acceptable. So we need to use heavier antibiotics and administer them systemically. The staff with a sore throat and fever or upper respiratory symptoms, we want to isolate them. We wanted to encourage them to take a day off, and we can make it clear by following CDC guidelines for healthcare personnel. And we don't mind, just like we were part of your team during COVID, and we followed all the precautions. We don't mind being asked to leave if one of our providers is exhibiting symptoms. Feel free to speak up. We obviously are encouraging this, non-threatening culture, making sure that company culture reflects on what our mission is, and our mission is 0 infections at the end of each week. This is what we're proud of, reporting most of the weeks 0 infection rates in our buildings and in our patient population. Again, follow CDC guidelines and DPH guidance, and during outbreak, we want to symptom screen all the staff, including consultants like us. And again, we wanted to be safe for the patients as much as we wanted to help and stay on the job. So sometimes the best thing to in terms of helping the building, is to stay home and make sure that you are recovering from strep throat. So mild cellulitis is beta-lactam, and this is your Keflex and your typical antibacterial coverage systemically, and mild cellulitis may be treated orally, but follow the guidance from your primary care provider, from your primary care physician of that resident. Group A strep, penicillin, clindamycin. Clindamycin does carry a risk of C. diff as a side effect, so we wanted to have this as add-on treatment. But again, follow the guidance from your primary care physician. Necrotizing fasciitis requires immediate transfer to ER for urgent and sometimes emergent surgery, followed by IV antibiotic. Massachusetts DPH requires report of invasive GAS within 24 hours, and in invasive case reportable to also local board of health. And Massachusetts DPH epidemiology program can be called by using this number, and they can be of help surveying the building and advising on further precautions. So invasive by CDC guidelines and definitions means isolated GAS from normal sterile site and wound accompanied by of necrotizing fasciitis. So in systemic signs and symptoms or spreading cellulitis, ascending cellulitis, so it's going up the leg, so that is very, very concerning and constitutes medical emergency. So report, notify, escalate the cases, and audit every case after the fact to make sure your prevention system is working and you are able to catch the cases earlier. Presume likely outbreak, even if it's one case, we want to take it seriously. We want to, again, analyze what happens. Most likely it's something that can be improved on the building, on a nursing team side. But it's also oftentimes the patient is not understanding, and maybe just despite us achieving the understanding, patient chooses not to follow the directions and not to follow medical advice. So those cases are unfortunately common, and we still are responsible for these patients, and we want to make sure that we do anything preventable, anything actionable on our part. And declared outbreak, and that is when you team up with your superiors, your infection control team that's available in the building and in your facility chain, but also you can involve DPH to help you with outbreak. Single invasive case, the slide's going to give you a little guidance on a sequence of event. So basically just summarizing what we already document. Time of recognition, precautions started when, provider notification, culture obtained, if any, transfer decision and timing, and contact screening and surveillance. Start precautions when you suspect the case. Use single-use or resident-specific topical treatments, if possible. Disinfect the instruments with sunny cloth wipes, if possible. That is advisable. Again, this is DPH epidemiology department guidance. Culture before the first antibiotic dose. Escalate when you see the necrotizing fasciitis. Red flags, report invasive cases, and document. Don't wait for confirmation of the case to isolate, especially don't wait for the results of culture, because that will take 2 or 3 days to identify sometimes. So gram stain may come in showing not very specific bacteria, but specific bacteria might be further identified in a couple of days. So we want to respond right away. We want to assume the worst, and so we wanted to notify primary care provider, start empiric antibiotics if needed. Empiric means you're not waiting for results of culture. You want to presume presume the most common bacteria, and we don't share the topical containers. We don't want to swab every resident, and don't assume that it's just cellulitis and not something that's actionable. For sure, do not delay necrotizing fasciitis transfer to appropriate surgeries and surgical ER. So we want to put everything together. We want to have great recognition system. We want to get a great prevention system based on the knowledge, based on the risk factors. Escalate when appropriate, report when you are required to report, and these habits hopefully will keep your building infection-free, and we wish you the best as far as keeping your patients safe and keeping your patients GS-free, Group A strep-free. We specialize in wound care and surgical dermatology. We practice infection control guidelines. Every provider that we send to the building has undergone at least 3 hours of Group A strep CME credit. So we spent at least 3 hours having education on, provider level education on Group A strep. So please use us as a resource, and we're happy to learn from you as well, because this is a two-way road when we teaching and we also learning from you. So no one is above anyone. We wanted to make sure that we work collaboratively and learn from each other. Again, single resident supplies, if at all possible. And we're happy to provide more in-services if this is something that's desired for your building. We can incorporate this in our typical 1 hour in-service if this is pertinent to the building. As a reminder, about 3 to 4 weeks ago, we had wound myosis, the maggots infestation of the wounds in service. So that is available in recorded form. We're happy to hear from you. If anything else that you would like us to focus on during in-services, we're happy to provide. Like I said, we have the lowest admission rates and lowest infection rates. Most weeks we report 0 infections and 0 hospitalizations, wound care related. In our patient population, the ones that's on our list, we're healing an average wound in 21 days versus 66 days. That's nationwide data suggests. We want to escalate and recognize the cases with you earlier, and we wanted to make sure that this is happening fast, and we don't want to see any deficiencies on the building. We want to make sure that we are responding appropriately to any changes in your practice environments. Just to summarize, we want to recognize Group A strep earlier, we want to isolate immediately, and we want to escalate fast if this is suspected cellulitis that's requiring IV antibiotics and we're not able to control the systemic infection by oral systemic antibiotics. And that's group 2 that we were talking about. We grouped by three groups for Group A strep superficial infection may be treated in the building. The middle is basically up to primary care physician judgment. In the third, the necrotizing fasciitis is immediate transfer to ER. Like I said, this session is being recorded for your colleagues who are not able to attend, and we will be distributing a recorded version later on by email. So we are going to conclude this, and again, like I said, we're happy to hear from you. We're happy to hear any feedback if you feel that we need to improve on the guidance that we presented, and anything that we can do at bedside. Please approach our provider, one of our providers on rounds, and I'm happy to hear from you directly as well. So here's my email, and most of the wound champions have my cell number to call if needed. So thank you very much for your time, and we will conclude the session.